Thank you, Lisa, for the nice introduction, and thank you, everybody, for coming in to attend this presentation. It was my privilege to present my research work that I have been devoting for the last 2 years at Ghent Institute for Environment and the Rochester School. And it would have been very great to do this presentation in person. However, for a reason, things are happening online, and I'm really excited to see you all and to present my findings. And it is a privilege to be part of this community, and I will keep continuing working with you all. Thank you very much. Having said this, I would like to share my slides. Can anyone tell me that if the slide is shared and it is in full mode? Okay, great.
Yeah, that looks great.
Great. Yeah, thank you very much again. And I will be talking about two very important issues of global importance, which is about the global environmental issue, which is deforestation, and the other most important global issue is public health. An example is malaria. So, which is really exciting to talk about these issues and contribute to the solution that Ghent Institute is contributing to science and knowledge and find solution. So before I'm just directly going to my research, I would like to introduce, I would like to say, which is a very important, catchy statement, which says nature and human health are inextricably linked. So nature provides us so much ecosystem services, including provisioning, regulating, supporting, and other cultural services. Among these include the regulation services, which involve disease regulation by controlling the vectors as part of biodiversity. And these vectors are especially for developing countries, causes for they transmit infectious diseases like malaria. So my talk will be about what is the relationship between malaria, forest cover loss, and human intervention or societal factors. Despite so much of the ecosystem services, human activity is leading to land use change, which has significant effect, which in tropics, for example, the tropical deforestation that changed 2% of the global land from natural state into anthropogenically dominated state. And the major driving forces are, among others, deforestation and agricultural expansion. As you can see, the figure on the right hand side, we see two huge economic activities. One is deforestation, followed by land use change into agriculture, rice paddies, and that is what I contributed to disentangle what would be the consequence of this change. So the literature already suggests that deforestation increases malaria rates in South America, in Africa, and Southeast Asia. Why? Because deforestation provides suitable habitats that favor efficient malaria vectors, Anopheles species. So, and this is the dominant vector species are well known, their biology, their ecology is known, but the relationship between their the disease they cause and that of the change in environment is still a growing field to understand. So, in addition to these economic activities, humans disturbance provides an important ground for to increase human and vector contact and that of parasite development. One is, for example, on the left side, we see people living near forest fringe areas or in a human disturbed natural areas where they are close to, where there is interaction between humans and vectors and related issues. On the right hand side, we see a clear land use change where these different forms of land have become suitable for vectors, for breeding, for survival, and for proliferation because human presence as well as human activities are important in order to increase malaria vectors productivity. So having said this, we see that the driving forces like the socio-economic activities and population growth and many other factors contribute to human health for good or bad. So human health in terms of, for example, infectious disease or communicable disease, usually there are problems of poor people or there are problems in developing countries. However, this trend is not direct. Instead, it takes their driving forces. And one of the driving forces that we said before is agriculture expansion due to population growth. That leads to environmental change, climate change, and deforestation. So these are mechanisms. And because of these changes, there is a change in vector psychology or interaction with the environment and interaction of vectors with humans. And that leads to our outcome, the disease outcome, for example, increase in malaria risk, especially for those people who live in poverty and those who have less productive agricultural system. I tried to show one example in my previous slides where people do not have protective mechanism while they are doing their agriculture practice. And indirectly, there is also the environmental change, which is caused due to deforestation or climate change, also impacts the poor people by transmitting other diseases like diarrhea or by through malnutrition or undernutrition. That is another issue, but my focus today will be on the relationship between environmental change or land use change and that of malaria. So, having said that, what is known in terms of malaria? We know that globally, malaria is a serious global health issue, where in Africa we see there are more than 100 cases per 1,000 population. Still, it is a huge number. So it is affects children under age of 5. If we see what is the data, World Health Organization reported in 2019 that nearly 230 million global malaria cases were recorded. Among them, there were 409,000 deaths, and from those, the most affected group of population are children under 5. When we see geographically, by geography, this malaria burden overlaps with that of poverty areas or areas where there is economic constraint and there is poor infrastructure development. This, for example, in Africa, 6 countries, Nigeria, followed by Democratic Republic of Congo, and other countries constitute greater than 50% of the malaria burden. But in general, Sub-Saharan Africa constitutes 94% of all malaria cases and deaths globally. This is a huge number. And as I said before, this is because the Africa, because of the climate, because of the land use change, because of the socioeconomic status, and in addition to the presence of extremely efficient vector species, the malaria still becomes a huge problem. So, considering this, there are global initiatives, both in terms of conservation of environment, in terms of addressing the issue. One of the global initiatives is the Sustainable Development Goals by the UN, where the Sustainable Development Goal 3 says good health and well-being is important. In order to address, I took 2 of the targets. That target 3.2 says to end preventable disease of newborns and children under 5. For example, in at least by 25 per 1,000 lives. If you remember in my previous slide, in Africa, the incidence is greater than 100 at the moment for children under 5 in case of malaria. The other goal is to end epidemics of malaria and malaria, HIV, and neglected tropical diseases. All these are targets for 2030. On the environmental side, the Sustainable Development Goal 15, the goal of this Sustainable Development SDG is to protect, restore, and sustainably manage terrestrial ecosystems, including forests and land degradation. That contributes to reducing vector-borne diseases. So these 2 are examples of where nations are supposed to contribute to the solution of the existing problem. And in terms of public health, the World Health Organization has also its own goals to address this very important public health issue, which is malaria disease. It aims to reduce the case incidence by greater than or equal to 90% by 2030, and to reduce mortality by the same figure. So all this shows that there is a need to address both environmental issues and public health issues in order to keep human health and well-being and sustainable society. And the global technical strategy for malaria under in WHO, one of the intervention they suggested or has been implemented is use of insecticide-treated bed nets and indoor residual spraying techniques in order to control vectors that transmit malaria parasites. If we see the ITN coverage or insecticide-treated bird net coverage in Africa compared to the 2000 in 2012, there has been a very significant progress where it has changed. I mean, the coverage has changed significantly in most African countries, and that was followed by a reduced malaria burden, malaria deaths and incidence until 2015, actually. However, this is challenged by the biology of the vectors, and because vectors become resistant to insecticides that are used in the ITN or in the bed net. So it becomes an issue because the endemic area still there is malaria burden is increasing, or at least it is stagnated. So considering this, the project that I've been working uses this just simple framework to study the relationship where we have deforestation and land cover or land use changes, which is influenced by demographic and social factors, including interventions or behavioral change like bird net use. And there are also ecological factors that include vectors abundance or vectors presence, their distribution, and the parasitic development, which is affected by humans' activity. And there is also, as I said before in my previous slide, that the human caused change in ecosystem increases human vector contact. That also contributes to increase in malaria risk for those people who are living in endemic areas. So considering this, we tried to address 4 research questions. These are some of them from the project, and not all are included here. So the first thing that we saw is we examined is what is the impact of deforestation on malaria prevalence on selected Sub-Saharan Africa countries by taking children under 5 years of age as a study population. And the second is, does the effect of on deforestation on malaria prevalence differ by household wealth? And the third is, do occurrence of dominant vector species moderate the effectiveness on malaria prevalence? The fourth is, does deforestation moderate the effect of bird net use? So just to give you a hint of what the study regions look like and where they are located. So this is based on the biomes and terrestrial ecoregions. So our study area are in the Sub-Saharan Africa, where the vegetation is mainly dominated by tropical and subtropical moist at the center, which is at the center near the equator, and it is also and mainly dominated by the grasslands, tropical grasslands, savanna, and shrubland. So this is the study area, which includes, which we took 6 countries, 3 from West Africa, 2 from Central and Eastern Africa, and 1 from Southern Africa, which is Mozambique, Rwanda, DRC, Democratic Republic of Congo, Togo, Cote d'Ivoire, Guinea, and this is Benin. So this shows the data on deforestation, where these countries are selected based on the extent of deforestation, where there is significant deforestation or forest cover loss, and there are areas where malaria is endemic. So in general, the data comes from demographic and health surveys, which was financed and supported by the United States, USAID. And in that data set, there are malaria indicators, and there are socio-demographic characteristics that we took for nearly 19,000 children under the age of 5. And the survey range years cover from 2010 to 2014. And we also used forest cover loss data, which between 1992 and 2011. And we also extracted vector occurrence data from Malaria Atlas project, which is one of the active research organization doing research on malaria. So just to summarize the data, what our data looks like, we have environmental data, we have demographic data, socioeconomic data, and climate data. And when we say deforestation, we defined it as land use conversion of forest into non-forest, and that was percentage of area forest cover between 1992 and 2011, the total percentage of forest cover area loss during that period of time. When we say bare net use, we are referring to whether children slept under insecticide-treated bare net last night. They were asked that question in the survey. So, so this data includes household level data, children level data, and cluster level data. And our outcome, malaria, is measured in terms of malaria prevalence. During the survey, blood sample was taken from children, and that blood sample was analyzed under the laboratory for the presence of parasite, Plasmodium parasite. So if the value takes 1, if Plasmodium parasite is found in the blood, otherwise 0. So I'm not going to go into the econometrics and the detailed model that I used, but it is good to point out that we used a multi-level hierarchical modeling or mixed effects logistic regression model, which accounts the different levels of data. And for that, we consider cluster and household as a random variable in order to address the issue of correlation or repeated measures. So coming back to the question, what is the impact of deforestation on malaria prevalence? This is just before that. This is the descriptive summary, which is malaria prevalence is nearly 25%, and deforestation is nearly 22%. All others are the covariates that we control during our model. So coming back to the result, before describing what this result means, this is this red line is a line that serves as a reference whether the effect is significant or not, or the relationship is significant or not. If the confidence interval crosses the red line, there is no relationship or there is no significant effect. If it is on the right side of the red line without crossing the red line, we call that there is a positive relationship or malaria prevalence increases because of the factor. If the value, the estimated effect is on the left side of the red line, we say that there is a negative relationship. That means there is a reduced effect on malaria prevalence. So based on this, we see that bare net use reduces malaria prevalence, or there is a negative relationship between bare net use and that of malaria prevalence. So bare net use reduces malaria prevalence nearly by 32%. So the deforestation, on the other hand, increases malaria prevalence, which is and it is significant. So our model suggests that net use and deforestation have effect on malaria prevalence. So that was the general model. So is this effect the same, or does this effect differ by household wealth? So with the same token, as I said before, the interpretation would be these are four different models for four different wealth levels: poorest, poorer, richer, and richest. So for deforestation, we see that as wealth level increases, the effect of deforestation declines to no relationship or no non-significant effect. So it means that being poor or having low socioeconomic status increases malaria prevalence in deforested areas. So, because those who are wealthiest, the wealthiest group of society, in those groups, we do not have evidence that suggests that deforestation increases malaria prevalence, but we see an effect on the other wealth levels at household level. So we see heterogeneity here. So there is wealth moderates the effect of deforestation. All other factors, we can see them. Some of them increase, others decrease, depending on the wealth level. The third result is, the third question was, do occurrence of dominant vector species moderate the effect of malaria prevalence? In Africa, there are 3 dominant vector species. So we have the data for those vector species, and we try to relate whether the presence of this vector species is associated with an increase with malaria prevalence or malaria risk. So here we have Anopheles species, 3 different Anopheles species. Basically, these 3 different Anopheles species are responsible for greater than 90% of malaria in Africa. So especially Anopheles gambae is the most dominant one, which transmits Plasmodium parasite from to humans. So here we see the blue shows the blue line, the blue mode. These are 3 models as well. So the blue shows areas where Anopheles gambae is dominant. The brown or dark red shows where Anopheles arabiensis, another vector, is dominant. And the green one is Anopheles funestus, which is areas where Anopheles funestus is dominant. So we see that deforestation is positively associated with increased malaria prevalence in areas where the Anopheles gambae and Anopheles funestus are dominant. Whereas in areas where Anopheles arabiensis is dominant, we don't see a significant relationship between deforestation and malaria prevalence. So we see that it is not only the mere existence of Anopheles vectors here important, and it is because which type of Anopheles species is dominant in that area to cause malaria. So we see that the effect of deforestation on malaria prevalence varies by the dominant vector species. So when we see bare net, it is Anopheles funestus, which is difficult to control in areas because you see it is non-significant, because that is resistant in most cases, in most, especially in areas where it is highly dominant. In Mozambique, the Anopheles funestus is resistant to insecticide, to insecticide that is used to treat bare nets. So all other factors, as you can see from the figure, have a robust kind of evidence to say that there is these factors are controlled in order to see the effect of deforestation. Our last question was whether deforestation by itself moderates the effect of bare net use. For this, what we did is just to recap about the general model from the previous trend, we see that bare net use and bare net use is associated with reduced malaria prevalence, whereas deforestation is associated with increased malaria prevalence. This is what we know from the general model. So what will happen if we stratify our data by different deforestation level to see whether bare net use has varied effect among different levels of deforestation. For this, we have these models. These models show, these models, we stratify the data by different deforestation level at 4 different deforestation levels. The lowest deforestation level, less than 5%, lower deforestation level from 5 to 20%, intermediate deforestation level from 20 to 50%, and and for those areas which have higher deforestation level, which is greater than or equal to 50%. So as we can see from this figure, we see that bare net use is associated with malaria prevalence differently for different levels of deforestation. For example, we see a clear evidence that at higher deforestation level, this orange color graph, we see that at higher deforestation level, bare net use is not significantly associated with reduced malaria prevalence. Whereas on the other levels, we see there is a bigger effect in that bare net is associated with reduced malaria prevalence. Especially, it is significant for deforestation levels of 5 to 20% and 20 to 50%. So in this case, as I said before, bare net use is defined as whether all children living in a household were slept under insecticide-treated bare net last night. So we tried a different model by considering that whether some or all children slept under bare net use last night. Here, what we included is some children in a household used bare net last night. So here we see that bare net use is negatively associated with increased malaria prevalence. That means bare net use reduces malaria prevalence in areas where deforestation is less than 50%. But if deforestation is equal to or greater than 50%, bare net use has no effect on malaria prevalence. That means the landscapes are too pathogenic. So this is an important evidence to support our previous analysis, which I showed you here. So bare net coverage, whether even if some children slept under bare net use, it appears that it has a reducing effect. Bare net use helps to control malaria vector, and then that could be attributed to reduced malaria risk. So finally, I would like to conclude my presentation with some remarks, where deforestation is one of the strongest predictors of malaria risk in Sub-Saharan Africa, especially in those areas where poverty, dominant vector species, and malaria endemicity is overlapping. The effects of deforestation depend on social and biological factors. When we say socioeconomic factors or social factors in terms of the wells, when we say wells, I think I didn't define it. Wells, it includes, it is a composite measure of education level, nutrition the water quality, the sanitary, the income, type of job, education level. All this is measured by our wells level indicators. And vectors ecology, the occurrence of vector species. So the effect of deforestation is moderated by both social and biological factors. So ecological changes, the other very important remark is ecological changes such as deforestation moderates the effectiveness of bare net use to control malaria. So deforestation not only has direct effect or indirect effects through ecological mechanisms, but also it has implications on the effectiveness of our gray infrastructure like malaria interventions. There are several hypotheses for that. So we recommend that future studies need to focus on spatial and temporal effects of deforestation, as well as it is good to look at the interaction between deforestation and bare net use at different in recent deforested areas and compare with older deforested areas, just to capture the temporal effect. So this is my last slide. Here we started with saying that there are global initiatives where countries are responsible, and these global initiatives include both environmental conservation and public health targets in order to keep human health well, and this can be integrated in order to the public health and sustainable development goals can be linked in a more integrative environmental conservation, so that by conserving our environment or by conserving nature, it is not only social and economic. It is not only economic benefits that we can get also health benefits. So that has implications for policy makers as well as for funders. And invest more on environment means invest on public health strategies indirectly that will complement other strategies like malaria intervention methods such as bare net use and insecticide spraying techniques. So I would like to thank you all for attending this presentation, and my collaborators, Taylor and Brendan, and Gandhi Institute for providing this postdoctoral research associate position at the University of Vermont. And I'm also grateful for the DHS program that allowed us to use the data and other funding sources which supported my fellowship at the University of Vermont during my stay in the last 2 years. Thank you very much.